Welcome to the GI Hepatology Academy, presented by Harvard Medical School. My name is Dr. Thomas Lamont, and you are tuned in to the live session called Approach to the Patient with Abnormal Liver Function Studies with Dr. Nizam Afdal. Dr. Afdal is Chief of Hepatology and Director of the Liver Center at Beth Israel Deaconess Medical Center in Boston. He is also Professor of Medicine at Harvard Medical School. Before we get started, I would like to remind our audience that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Afdal.
Thanks, Tom. So today what we're going to do is talk a little bit about how we clinically, in real practice, approach a patient who has chronically abnormal liver function tests. And then at the end, look at some of the newer technologies that are available to us for the staging of chronic liver disease and how we are moving away from the utilization of liver biopsy. So, the first thing we have to look at is really what is the definition of chronicity. Many times we refer to patients who have one abnormal liver function test, and we have to say, well, we rarely fully evaluate patients with just one isolated elevated abnormal liver function test, and we usually like to see that there's at least one or more elevations over a period of 12 weeks or so to start thinking about the causes of chronically abnormal liver function tests. And we have a variety of what we call liver function tests, and these include tests of hepatocellular injury and tests of biliary injury or cholestasis. The cholestatic enzymes are the alkaline phosphatase. This is an enzyme located in the biliary epithelium, also present in bone, can be fractionated to differentiate liver from other organs, but it's usually easier and cheaper just to do a GGT or gamma-glutamyl transpeptidase, which when elevated along with an alkaline phosphatase elevation almost always indicates that you have cholestasis or biliary injury. The 5' nucleotidase is not used much anymore, but again, some people will use it for evaluation of cholestasis. The aminotransferases are hepatocellular enzymes. The ALT is in the cytosol, it's near the cell membrane, and it is predominantly a hepatic enzyme. And elevations of ALT nearly always indicate a primary hepatic injury. The AST, on the other hand, is a mitochondrial enzyme. It's found in lots of other organs. And often I get sent patients with elevated AST only, and they turn out to have an AST from a non-hepatic source, frequently muscle. And I always say to my fellows, make sure you ask people about their exercise regimen, because vigorous active exercise can raise the AST. The LDH is often used as another test of liver function, but this is non-specific and is only helpful in particularly special situations such as ischemic liver injury, where it can be disproportionately high. When we see patients who have abnormal liver function, the first thing to do is to try to divide them into which category they are. And there are obviously two pure categories, cholestasis, hepatocellular, and then there are a lot of patients who have a mixed type injury where they have both features present. If you have an alk phos elevation that is persistent, it needs to be evaluated. If somebody has normal or minimally elevated transaminases and even a normal bilirubin, that may be somebody who has cholestasis, and a disease that can be quite significant can present with just an elevated alkaline phosphatase. We often also get referred patients for an isolated elevation of the bilirubin. The commonest cause by far for an isolated elevated bilirubin is Gilbert syndrome, which can be differentiated by the fact that indirect hyperbilirubinemia is present, and the indirect is much greater than the direct. The other common cause that people forget about quite frequently is heart failure, which can also cause isolated indirect hyperbilirubinemia. So these are things that I look at when I'm evaluating a patient. For hepatocellular, you should have ALT-AST elevations. For most patients, ALT should be higher than AST. The only situations in which AST is higher than ALT is people who have alcohol-induced liver disease and people who have advanced fibrotic liver disease, particularly people who have cirrhosis, where there is a reversion of the AST-ALT ratio so that the AST is significantly higher than the ALT. Besides looking at these, one of the first things that I always have to do is to evaluate how is the patient's synthetic function. In fact, this is probably the most important thing that we do as hepatologists, because Elevated transaminases per se do not really put a patient at risk. However, alterations of true synthetic function do put a patient at risk because they indicate significant liver injury. This can be acute or chronic. For example, in a patient who has an acute hepatitis or an acute Tylenol ingestion, if there's an elevation of their tests of synthetic function, such as the prothrombin time or the INR, that's highly indicative of severe hepatocellular damage. So in every patient, in addition to the enzymes that we measure for cholestasis and for hepatocellular injury, I need to know the albumin, the prothrombin time, and the bilirubin. This panel of tests altogether gives me a true evaluation of what the patient's status is. And again, low albumin, high prothrombin, and elevated bilirubin are all indicators of severe hepatocellular injury, whether it is acute or whether it is chronic. Elevated ALT is very, very common. So in the NHANES 3 study, there were about 16,000 patients over 17 years of age, and almost 8% of them had an abnormal ALT. And that was taking the cutoffs of 40 IUs for a man and 31 IUs for a woman. And these may actually be high cutoffs. It may be that the normal range for a man should be less than 25 and for a woman less than 19. But remember, this is a national average in a country where we have quite a lot of obesity and diabetes, which pushes up the average ALT, if you want. And the AST levels were also elevated. More frequent elevations were seen in men than in women. When people looked at the potential cause of elevated ALT, 69%, almost 2/3, had an unexplained elevation that was not due to hepatitis B, hepatitis C, alcohol, or iron, because all of these were studied in the NHANES study. So these were all measured. What there was an association with was the presence of metabolic syndrome, and a high BMI, big waist circumference, high triglycerides, high fasting insulin, type 2 diabetes, hypertension, and low HDL were all significantly associated with high ALT-AST. What is this? This is obviously the prevalence of non-alcoholic fatty liver disease in the US population. As you've heard this morning from Dr. Chopra, this is a phenomenally common condition here. Maybe metabolic syndrome involves as many as 35 million people in the US today, which would fit into the numbers we're talking about here. What's really interesting is that there are other studies that have suggested that actually an isolated high ALT is associated with an overall increase in morbidity and mortality. And there are studies that have come out, particularly from Glasgow and in the UK, where a high ALT was associated with an increased risk of all-cause mortality, but particularly cardiovascular disease-related mortality. So having a high ALT is a signal not just of liver injury, but also can be a signal, as is shown here, of the concomitant metabolic injury that's seen in a lot of our patients. We have to have in our minds what are the most common etiologies of abnormal liver function tests. And whenever we see a patient, we really should just run through this checklist to see where they fit. The first thing I always do is I look at how high are the Lfts, particularly the transaminases. And there are very different differentials for transaminases between normal and 400, 400 to 1,000, and greater than 1,000. When you're looking at transaminases that are above 1,000, you're really looking at acute severe hepatocellular injury. This means acute viral hepatitis, acute ischemia or ischemic injury to the liver, acute biliary injury, such as an acute cholangitis, which will often have pain, fever, and cholestasis with it, and acute drug-induced injury. All of these will give that very high level above 1,000. But most of our patients are actually in and around the elevated transaminases between the upper limit of normal and 200. That's where the majority of patients fall, and here the differential is broad. We put at the top non-alcoholic fatty liver disease, most common cause in both the US and Europe, and a phenomenally increasing cause of elevated ALTs in people from developing countries where our American diets are increasing. You only have to go to Shanghai or Beijing to see a McDonald's now on every corner. So as the world becomes McDonaldized, we're seeing significant increases in fatty liver disease all around the world. And the prevalence in the US could be as high as 25% of the population. Alcohol use. Alcohol is a very important cause of elevated transaminases. And as I said, one of the keys is if the AST is higher than the ALT. Another key is if the GGT is elevated, because that can be induced quite rapidly by alcohol. But a good alcohol history is vital and necessary in all patients with abnormal liver function tests. Medications. In amongst medications, I've thrown in herbals, because nowadays people take as much over-the-counter, particularly herbal medications, as they almost do prescribed medications. And many of these have the potential to cause some hepatotoxicity. One has to be aware that abnormal transaminases are frequently seen 1 to 2% of cases with almost any of the common medications that we use. We're all aware of the risks associated with drugs such as statins, but a good medication history is critical. Hepatitis C, 2% of the population. Hepatitis B, somewhere around 0.5% of the overall population. But in certain ethnic groups, about 10% of the population will have exposure to hepatitis B. Hemochromatosis, 1 in every 300 to 400 Caucasians, particularly those of Northern European, Scandinavian, and Celtic descent. And then hepatitis A, but that's frequently a higher level of transaminases. We do also have less common causes, autoimmune liver diseases, and we have seen an increase in autoimmunity, both autoimmune hepatitis and the biliary diseases, primary biliary cirrhosis and PSC. Wilson's disease, a hereditary disorder of copper, alpha-1 antitrypsin deficiency, and other genetic metabolic causes. And right at the bottom, we've put down the surgical causes, biliary obstruction, gallstone disease, metastatic cancer, because actually they fall into the significantly less common etiologies of abnormal LFTs when we look at patients altogether. But they're what we're all worried about, because we don't want to miss any of these things because of the potential for surgical treatment. So we've got this background of what we're looking at in our patients, and then how do we actually go ahead and evaluate these patients with abnormal ALT? You know, when I went to medical school, my professors told me that the history and the physical exam gave you the diagnosis in 90% of cases. The reality is that in abnormal ALT and abnormal liver blood tests, the history gives you the diagnosis in 90% of the cases. So there's nothing that beats a good history, period. You really want to know all about the patient's prior history. Did they ever have liver disease? Did they ever have jaundice? Did they ever have any exposure to any risk factors associated with jaundice, hepatitis, etc.? What is the family history? Lots of liver diseases have familial backgrounds to them. Hemochromatosis, for example. Strong family history is often there. Family histories of diabetes, obesity, elevated lipids. Drug use, particularly steroids, anabolic steroid use, over-the-counter meds, all of those things are important. Alcohol. You know, if alcohol is a common cause, you have to take a good alcohol history. Most patients, as we well know, will understage their use of alcohol, but many patients will, as you talk to them, confess that the alcohol usage can be greater than indicated. Meds and then herbal products are critically important. If you take this history and you spend enough time on it, I honestly guarantee that 90% of the time you will have worked out what the cause of the abnormal liver blood test is before you lay a hand on the patient or order a single test. The physical exam is fairly straightforward. Most people actually have no findings on physical exam. You have to know what the weight, BMI, and blood pressure is for metabolic syndrome. The liver size is important. Many patients will have hepatomegaly. A good examination of the liver is important. The liver will often be firm and smooth. Very rarely is it nodular, except in cases of cirrhosis. Sometimes you might feel a large left lobe in a cirrhotic patient, and then you have to look for all the signs of chronic liver disease and cirrhosis as indicated here. All of these signs of very advanced liver disease. But overall, I find the physical exam is not particularly helpful, except maybe for confirming risk factors for metabolic syndrome. Now, in primary care, what do you want to know? What do you need to get right off the bat so that you can look at the patient and then decide whether you want to refer them? Because if you referred 9% of your patients to us, I would have to retire. So clearly, you need to try to figure out which patients do or do not need referral. So fasting glucose lipids. metabolic syndrome, high triglycerides, high glucose, not necessarily in the diabetes range, but a high glucose. Sometimes it's useful to do an insulin test with that. If you do a fasting insulin and glucose, and then you measure the two tests and calculate the insulin glucose index, you can see if the patient has metabolic syndrome. Repeat the liver blood tests. Always repeat them. If you've got one set that's abnormal and you're not sure what to do, it's okay to repeat them, because many times people will have transient elevations. It might be related to a viral infection, might be related to a minor medication ingestion, so repeating them never hurts. You need all the synthetic tests, bilirubin, albumin, INR, etc. You need the cholestatic tests, alkaline phosphatase, GGT, CBC, and then because iron storage diseases are so common, let's get an iron TIBC, work out the percentage iron saturation, work out the ferritin. Above 50% in men, 40% in women, you need to be thinking about possible iron overload, especially if associated with an elevated ferritin. In primary care, I truly believe you should be doing the appropriate tests to rule out the common viral hepatitis agents. Everybody with an elevated ALT should get a hepatitis C antibody and hepatitis B surface antigen. You don't have to do anything more than those two tests, but those two tests will pick up for hepatitis C antibody 99% of HCV positive patients, for hep B surface antigen 99% of people with chronic hepatitis B. You don't need the other tests. Those are the two screening diagnostic tests. In women, particularly if the ALT-AST is above 200, rule out autoimmunity. And you do an ANA, smooth muscle, IgG, IgM. And if you have a high alkaline phosphatase, an antimitochondrial antibody for primary biliary cirrhosis. Most patients will have an ultrasound of the liver before they come to us. I think that's a good idea. You do the ultrasound to look and see if there's fat in the liver, what's the shape of the liver. Some people do it to rule out liver cancer, liver masses, but they're rarely found there. And then platelets, serum fibrosis markers are specialized tests that can be done. Platelet counts that are low. Commonest cause of thrombocytopenia is still chronic liver disease. And so these are useful tests to evaluate the patient. I think if you do this panel with a good history and physical, you should have picked up 90 to 95% of the causes of your patient with chronically elevated liver disease.
Dr. Ocanedo from Beverly, Mass. asked the following question apropos of this differential diagnosis. How will HIV/AIDS infection pan out in the etiology of abnormal LFTs?
So patients with HIV can have abnormal LFTs. There is an association of an actual HIV hepatitis, but it's not a common presentation of HIV at all. I think HIV is picked up much more effectively through appropriate risk factor-based screening and history taking. They don't usually present with isolated elevated liver blood tests. Obviously, when somebody tests positive for hepatitis C, then it is mandatory to do an HIV test, because the etiology, the modes of transmission, are often very similar in those. And so we recommend HIV testing in many of these things. But in a female who comes in with elevated transaminases and no risk factors, HIV is probably not going to be your answer. For young people, think about other things. These are some of the other things we think about. These are perhaps the second tier of tests. Not necessary to do in the primary care setting, but when they come to us, we often think about, well, have we checked their copper status? Could they have copper storage disease? Check a copper and ceruloplasmin. Alpha-1 antitrypsin. That deficiency can result in both pulmonary disease and liver disease. Sometimes we pick this up by taking a good history and hearing about a patient's family history of COPD and a non-smoking parent. And then you check them out and they have alpha-1 AT deficiency. Celiac disease, a very interesting disease that again is quite common, much more common than we think it is, can be associated and present actually with abnormal LFTs. And then the hemochromatosis gene test for males with iron saturation above 50 and females above 45. So these are our secondary line, if you want, of tests that we look for. So let's look at a patient. So this is a very healthy 23-year-old female pharmacy student, no problems, got shingles on the scalp and was treated with Valtrex. Got a history of malaise, fatigue, and weight loss, wasn't feeling very well. She had her lab test checked, and she had a white cell count of 2.9, which is low, platelets 89,000, ALT 140, AST 98, so elevated transaminases. Her INR was 1.1, albumin was normal, bili was normal. So here's a lady that, in our definition that we talked about, has some strange things going on. She's got low platelets, low white count. That makes me a bit worried, but normal hepatic synthetic function. INR, albumin, bili, okay. Elevated transaminases. So what could be going on here? So obviously she's young. The transaminases are pretty high. We probably do that battery of tests that we talked about before. We certainly want to rule out hepatitis B and C. She doesn't have any features to suggest metabolic syndrome or Nash. She's got this non-specific fatigue, weight loss type thing. So we would get a test and an ultrasound. Ultrasound, wow, 17 centimeter spleen and a nodular liver. Query varices. Let's go back a slide. 23-year-old healthy pharmacy student. So now we're thinking, well, this is something that really is strange. Good synthetic function, splenomegaly, nodular liver, features to suggest cirrhosis on the ultrasound. Could she have unexplained autoimmune disease that's caused this type of thing with progression over time? Would she be at risk for that? Could this be a manifestation of systemic disease and stuff? She's got this non-specific malaise and fatigue. Let's look at her blood tests. Hepatitis A, immune. Hepatitis B, surface antipositive, vaccinated. Hepatitis C, negative. Iron sat, 20%, not hemochromatosis. ANA, normal. Very high anti-smooth muscle antibody, 1 in 640. AMA, anti-LKM, normal. ANA, negative, anti-smooth muscle positive, could be autoimmunity, not that common Hep B's, not common Hep C, not iron storage. Young person, we should probably get copper, alpha-180, do all of those things. Celiac. Look at her celiac disease score, very, very high. She's got this weight loss, this malaise, this fatigue. Look at her endoscopy. A nicely scalloped looking appearance to her small bowel and duodenum. Biopsies confirmed total villus atrophy. And this patient actually was a 23-year-old female that presented with celiac disease as abnormal liver function test and had developed cirrhosis at that time. And there is this whole syndrome of celiac hepatitis. About a half of all untreated celiacs get abnormal liver function tests. It's very strange. You give them a gluten-free diet, and guess what happens to the liver tests? They actually get better. It may take up to 6 to 12 months, but it happens. But what's really interesting is that when we look at patients with advanced liver disease, such as from a very nice study done in Finland, 4% of patients who underwent liver transplant, where celiac is common, had celiac disease. And there is this concept of celiac-induced chronic liver disease and cirrhosis.
We have a question in that regard from Dr. Dawn Ball. In regards to celiac disease, will the LFT range present as just abnormal, or is it, can it go higher, or is there a range?
No, that's a typical range that you see. It's usually less than 200, and the etiology is unknown, but there's a feeling that it's part of an autoimmune type process that takes place, this so-called celiac hepatitis or cryptogenic hypertransaminasemia. They're not going to be above 400 for sure. It's usually in and around the 100 to 200 range that you see the transaminases.
And speaking of herbals, there's, as you know, hundreds of them in the store. Do you have some favorite ones that we should ask about, or?
Black cohosh, my friends tell me, is very bad for you. You know, all of the herbals that are associated with anabolic steroids. We presented a whole series of cases, Fred Gordon, Leahy, and myself, where there were young men, this is a very typical scenario, young men who are doing bodybuilding. And they buy these over-the-counter herbals. They're called natural steroid substances, and they actually contain anabolic steroids, but they're not regulated. And they end up getting tremendously severe cholestatic hepatitis. It can last for months. But if you really want to know, the NIH have a fantastic website that is all about herbal-induced liver injury, and you can go on that website and basically look up almost any herb you've heard of and some you've never heard of. The real problem is when you get a patient that comes in from China and hands you a bottle and says, I'm taking this, and you're like, wow, what is this? It's all in Chinese. But you know, you've got to try to figure it out. Sometimes telling them to stop these things is good, as a good way of doing things. All right. Why do we need to evaluate these patients? Because there are diseases that we don't want to miss. These are a list of the diseases. B and C, obviously, there are treatments for those. Hemochromatosis. The most curable liver disease in the world is hemochromatosis. It's also one of the cheapest to cure. You just do phlebotomy. So, the fact that we still see patients presenting to us with cirrhosis, diabetes, liver cancer from hemochromatosis is quite distressing, because really, you think that we should be able to pick this up with a very cheap evaluation of iron, ferritin, etc. Autoimmune hepatitis, very aggressive disease. Somebody with autoimmune hepatitis can progress to cirrhosis in a very short period of time. It's one of the most necroinflammatory profibrotic diseases there are. So again, important to pick up because treatment is highly effective in these patients. Primary biliary cirrhosis, and then obviously Nash. But Nash, the treatment is lifestyle modification, and most of us as good physicians will tell our patients to avoid carbohydrates, exercise more, and most of our patients will ignore our advice. Who should we refer? This is often a big question because, we don't want to see 9% of the US population, but we do want to see people that we think have eminently treatable diseases. Unexplained elevations on 2 readings, something that you can't explain. It's not a drug. It's not Nash. It's not. It's something that's unclear. Those people should come. Everybody with hepatic dysfunction should be referred. If you have patients with hypoalbuminemia, hyperbilirubinemia, prolonged PTINR, thrombocytopenia, and you don't know the reason for it, those patients should come. They have advanced liver disease. They need to be evaluated. And obviously, if you pick up the cause of the elevation and you do a Hep C antibody and the patient is positive, then those patients are also reasonable patients for referral. So elevated liver enzymes occur in loads of different disorders. We didn't even touch on systemic diseases, but many systemic diseases will affect the liver as well. It's one of the biggest organs and is affected by lots of chronic inflammatory conditions. Patterns of elevations are relatively important in differential, and the investigation initially is not too complex, but will help in referring the patients for optimal management of disease. Often the biggest question that the primary care doctor says is, if I refer this patient, what am I referring it for? Is it for a liver biopsy? All right? Liver biopsy is something that's done by hepatologists, by radiologists to evaluate liver injury. When do we really, really need to do it? If I have somebody who I can't explain why the ALT is elevated, I'll do a liver biopsy. If I have somebody with unexplained hepatomegaly, fever of unknown origin, I'll do a liver biopsy. Those are pretty much definite indications for a liver biopsy. Serological tests, clinical findings, provide the diagnosis in 90% of cases. Most of those cases, I won't do a liver biopsy. The average patient who comes to us with Nash does not get a liver biopsy. We don't need to do a liver biopsy to make the diagnosis of Nash. Oftentimes, we can do it based on the exclusionary serological tests and clinical features of risk factors for metabolic syndrome. Treatment decisions. Sometimes a liver biopsy can be very important in making the decision to treat or not to treat a patient. People who have more advanced disease, more injury and scarring, you may use that biopsy to help you in deciding whether to treat them, particularly true for diseases like hepatitis B. But again, less necessary these days with our better tests. Staging the liver disease. Patients want to know. They're scared when the liver functions are abnormal. They want to know what's going on. So should we be staging fibrosis for prognosis? That is an important thing. Sometimes knowing how much damage a patient has is very important for prognosis. So looking at that, the common 3 liver diseases that get biopsied are Hep B, Hep C, and Nash. And they're usually biopsied for only one reason, and that's to stage the liver disease. Excuse me. Why do we stage it? Fibrosis severity is the most important prognostic factor. The amount of scarring is the most important thing that determines prognosis. Fibrosis severity determines the urgency of treatment. With all these new drugs coming along for hepatitis C, we don't need to treat the mild disease patients. But if somebody has advanced disease or cirrhosis, there might be an urgency to treat them today. This is the absolute sine qua non of why you have to stage fibrosis, and that is that identifying cirrhosis is vital, and it is the most important thing in terms of getting the patient's liver health in shape. People with cirrhosis must be screened for varices and hepatocellular cancer. Even if you've treated their hepatitis B or C, they still require you to follow them for these risks, particularly the risk of hepatocellular carcinoma. And sometimes we think that the amount of scarring is important in treatment, but that's less so. And sometimes we use scarring for treatment decisions. But here is the major reason why we look at scarring. If you look at this, liver disease takes a long time. Most patients take, whatever the cause of the liver disease, whether it's Hep C, Hep B, or Nash, they take 10, 20, 30 years to develop cirrhosis and liver cancer and liver failure. It doesn't happen overnight. It's truly a chronic disease. But once it happens, you're at risk for all of the things. And the risk factors are really quite clear. The duration of your infection, which is proportional to the amount of injury and scarring you have. Males with all liver diseases do worse than females. Alcohol, older ages, patients do worse. And so all of this stuff helps us determine what we should be doing for the individual patient. And all of these things lead to increased risks of fibrosis. Why do we do it? This is a patient with varices. Our guidelines are quite clear. People who have cirrhosis must be screened for varices. People who have varices are at risk of bleeding. Bleeding from esophageal varices is bad, and esophageal varices can be treated very simply with a non-selective beta blocker. We use nadolol, propranolol, very simple, very effective. Relative risk reduction for bleeding is more than 70%. Hepatocellular carcinoma, growing problem in the US. ASLD guidelines, again, are very clear. Patients who have cirrhosis need to be screened for hepatocellular carcinoma. Why do we screen them? Because if we pick up small hepatocellular carcinomas, they're eminently treatable. If we wait until the carcinoma presents clinically, it's often over 5 centimeters in size, and that patient cannot be effectively treated. And that carcinoma cannot be resected and or treated with local regional ablative therapy. So it's a big issue for us. So identifying cirrhosis, vital thing to do. Liver biopsy. So we talk about liver biopsy fairly easily. We do a lot of liver biopsies, but a liver biopsy to a patient looks rather like this. Drilling a nice hole in the patient's liver and taking out a piece of tissue. It's amazing the fear that the word biopsy and liver put into a patient's psyche. So we would like to avoid doing a liver biopsy. Why else don't we do liver biopsies? One of the reasons is that liver biopsies are not the most accurate thing. This is a study that we did looking at 3 different major liver centers, asking pathologists to stage liver disease. And they're very good at saying you have no scarring, and they're very good at saying you have cirrhosis, but they're awful at saying there's mild, medium, or moderate scarring. It's all over the place. They cannot agree as to the degree of scarring. So obviously, and it's not something that you can repeat multiple times to see how things are going. Most patients after one biopsy don't really want another one a year or 2 years later, So the ability to actively look at the liver over time is impaired. So this has led over the last 5 to 7 years of tremendous plethora of choices in how we evaluate patients' liver disease. So I want to know, like I said, how much damage and scarring does my patient have? And I need to know that preferably without doing a liver biopsy. And there are all these different methods out there for doing this, and I'm just going to address 1 or 2 of these different types of methods. I'm going to talk a little bit about the concept of transient elastography, which is a phenomenally easy, user-friendly and patient-friendly test to evaluate the degree of liver stiffness or fibrosis that's present in the liver. It's an immediate test. It has less sampling error, and it's a bedside procedure. In fact, we do this in our clinic, and it takes less than 5 minutes per patient. The patient is put on the table in a position for doing a liver biopsy, and a little transducer is placed against the skin, and a shear wave is passed into the liver. And the velocity of that shear wave is proportional to the stiffness of the liver. So here it is conceptually in a physics type environment. So you've got this generation of a shear wave. It goes through the rib cage into the liver. So there's the little There's a little blip that causes the shear wave to pass into the liver. The shear wave is passed into the liver, and you measure the velocity of that shear wave. And as you measure the velocity of that shear wave, you can determine the speed in meters per second it goes through, and then convert that into liver stiffness. And then what you have is a measure that is reproducible, that tells you how stiff the liver is. And this test is incredibly patient-friendly. In fact, if you refer a patient to our liver center, most new patients get this right off the bat. They can come in and we can tell them, hey, don't worry, your elevated ALT is not associated with significant scarring and/or fibrosis. We've done a liver stiffness test and it reads pretty well. It works very well, but there are cases in whom it doesn't work. The biggest issue where it doesn't work these days is related to the concept of obesity. So just like everything else in the world, we are supersizing elastography, and we have a new probe called an XL probe for extra large. And this enables us actually to do elastography in patients that are obese up to BMIs of 40. So this is a highly clinically useful test. I think of this as the echocardiogram of the liver. Tells you a lot about the amount of damage that's present in the liver. And the good news is that this was approved about 3 weeks ago by the FDA, and we hope that it will be utilized in more than just specialty centers like our own. You have to understand the principles of stiffness. Stiffness is not just scarring. Congestion, inflammation, cholestasis can all combine stiffness. So it has to be interpreted by somebody that understands the principles of what's going on inside the liver. Does it work? This is a meta-analysis of all the studies that look at elastography to measure cirrhosis. And the area under the curve is a way you can measure the effectiveness of a test. In the panel on the right, what you see is the area under the curve for the diagnosis of cirrhosis. It's 0.94. That's as close to 1 as you can possibly get in a clinical test. And what it means is that we can use this test very effectively to both diagnose cirrhosis and exclude cirrhosis. And since the diagnosis of cirrhosis is the most important aspect of staging a patient, we find this an incredibly useful test.
So can I ask, is the sensitivity 84 and
so
the previous
that is for determining the presence of no significant fibrosis versus moderate to severe. Okay. And there the AROC is 0.84, but for cirrhosis it's higher, it's 0.94. So the ability to diagnose and exclude cirrhosis is very good.
Dr. Catherine Miller, who's watching, asks if this FibroScan test can replace liver biopsy.
So in the UK health authorities have said that it is no longer justifiable to biopsy patients with hepatitis C for evaluation of liver disease. They have to have elastography. In France, the number of liver biopsies has fallen by 90%. And these are countries which were early adapters of this technology. Mm-hmm. So these non-invasive tests are going to change. I don't know how many of you were on for my hepatitis C talk, but imagine that the power of these tests in terms of determining which patients can be treated in primary care versus which need specialists. A simple 5-minute non-invasive test can help you do that. But in addition to that, Tom, I want to point out this thing, which is not only have the tests gotten better for elastography, but also we've developed serum tests that measure liver fibrosis. And these are what I call fantastic bucket tests. So what they do is they have an ability to bucket people. If you score really low on these tests, you have mild liver disease. If you score really high on these tests, you probably have advanced liver disease. It's best illustrated here in this thing. And this is what's called the Fibro test. And here what you can see is that people who score between 0 and 0.2, they have more than a 90% chance of having F0 disease. People who score greater than 0.73 have more than a 90% chance of having significant fibrosis. And again, when these tests are done in collaboration with a test like elastography, you get a double evaluation. And the double evaluation is absolutely the best way to do this. So when you combine these tests, you improve the overall diagnostic accuracy, both for non-cirrhosis and for cirrhosis. And we recommend combining a serum test and an elastography. And For 95% of our patients, this is enough. And we apply it in all disease states: Nash, Hepatitis B, Hepatitis C. And this helps us to determine which patients have significant liver disease or not. What's really interesting is that you might say, well, prognosis, you're telling us stiffness. What's prognosis? So we and others have studied this and shown that if you score low on these tests, that you have a 99.7% chance with a liver stiffness of less than 10 of having no clinical liver-related events in 5 years. And so I can tell my patient, your stiffness is low, your chances of having a liver event are markedly reduced. So these technologies should change our diagnostic approach to the patient with abnormal ALT. It should be ALT abnormal, figure out what it is, stage their disease in a non-invasive fashion. And I think that that's where we're moving to. All right. There are all sorts of other ways to do it, just for comparison. This is something called virtual touch or acoustic resonant force impulse elastography. Here, instead of a transducer doing this, you actually give a push against the liver, measure liver stiffness, and then the highest tech level is magnetic resonance elastography, where at the time of an MRI, a patient can actually have a total liver elastogram, and you can actually look at regional differences in stiffness. So this technology is moving forward tremendously and has huge applicability in how we evaluate patients. So, I hope that this talk has shown how we think in liver disease, how we look at a patient, how we evaluate them, and also maybe touched on some of the exciting things that are coming in our future in terms of helping stage and give prognosis to our patients with liver disease.
Thank you. We have a few more questions we can go over here from our viewers. Dr. Eduardo Pirola says, given the occurrence of celiac disease and inflammatory bowel disease, ulcerative colitis and Crohn's disease, should we request blood tests along the lines of ASCA? These are tests for determining the possible frequency of IBD, antimicrosomal antibody, endomysial, alpha-1 antitrypsin, and anti-gliadin tests.
So I think there's a very strong association between celiac and inflammatory diseases and autoimmune diseases, and I think it's reasonable to do that. What I would do first of all, and what we see a lot of because it's done in our practice, is our IBD experts do often liver function tests, AST, ALT, and ALPHOS in our IBD patients. Sometimes they send the patients to us with elevated ALT, AST, and it's an inflammation, non-specific. The liver's just involved. Occasionally, the ALPHOS will also be elevated, and these patients may have primary sclerosing cholangitis, a disease that is very important to pick up, that is associated with significant morbidity and mortality, and more frequent in patients with IBD. So, yeah, I think that these GI diseases, the GI and the liver, even though we consider ourselves separate specialties, myself and Dr. Lamont are always talking hollow organ, solid organ, we believe that they are closely linked immunologically and functionally.
For sure. Here's a question from Dr. May Denjalern. Is it possible that a patient has liver disease presenting with chronic thrombocytopenia, but inconsistent mild elevation of some Lfts and otherwise normal CBC? What would you think of that?
So not only is that conceivable, but it is highly conceivable, as in a patient I saw today, that a patient presents with nothing but thrombocytopenia and has significant liver disease. So you can have a patient who has nothing but thrombocytopenia and they have advanced established cirrhosis. Remember, as the liver becomes more scarred, there's less hepatocytes to release ALT and AST. So the transaminases are often normal in cirrhosis in cirrhotic patients. And the isolated thrombocytopenia, any hematologist will tell you, can be a significant part. And the reason for that is that thrombopoietin, the hormone responsible for platelet production, is actually synthesized in the liver. And as the liver gets damaged, the lack of thrombopoietin results in thrombocytopenia. So yes, absolutely, that's something you should always think about when you see somebody like that.
I wonder if you could comment for Dr. Ionesco, who asked about the applicability of statin and fibrate therapy to improve NASH.
So what we recommend is, without a doubt, good control of metabolic abnormalities, including hypercholesterolemia and hypertriglyceridemia are very important. Most NASH patients actually have more hypertriglyceridemia. So low-fat diet and the use of a fibrate are fine in NASH. We don't know if they change or alter the natural history of NASH with respect to necroinflammation, but they are very important because the number one cause of mortality in NASH patients is not liver disease, it's actually cardiovascular disease. So it's clearly important to control cardiovascular risk factors. So yes, we recommend it. By the way, I want to throw this plug in as well. We also recommend statin use in anybody with liver disease who has hypercholesterolemia. People are scared to put a hepatitis C patient on a statin. They shouldn't be. If the cholesterol is high enough that it requires treatment, you should treat it and monitor the liver tests as you would do any other patient on treatment. And in fact, one of the problems that we found in one of our huge 3,000 patient US studies was that only 9% of patients who should have been on statins were actually on statins with hepatitis C. So I make a plug that if you think as a doctor that patient needs control of his cholesterol, go ahead and do it, even if they have liver disease.
Here's another question from Dr. Pirola. He discusses the elevation of CA19-9, which can be elevated in extrahepatic cholestasis. So how do we use this test if we're concerned about a patient with neoplasia plus minus liver disease?
This is a marker that's elevated in several specific conditions. So it's associated with cancer in that it's elevated particularly with pancreatic and cholangiocarcinoma, where levels can be high, but it can also be released secondary to acute biliary inflammation. So in somebody, for example, with acute cholangitis, you can have very high levels of CA19-9. You know, to be honest with you, I use it as a screening test in PSC patients. I use it as a confirmatory test. It's not something that's mainstream, really. Often, by the time it's elevated, the tumor is obvious on imaging, MRI, CT scan, will show pancreatic or cholangiocarcinoma.
Earlier in your talk, you mentioned that people getting a lot of exercise, or such as weightlifters, can have minor elevations of AST. Is it AST or ALT?
It's AST.
AST. How high and how do you test for it? Do you get a CK at the same time?
Yes. So I want to illustrate a case. I had a wonderful patient that I treated and had cured a hepatitis C, and she was doing great. And young girl, she went out and she did some sort of new bodybuilding type, heavy weights type thing. And she went to a primary care doctor who said, oh, she's got terrible liver failure and liver problems because the AST was high, and she did a CK and it was 5,000. The AST was about 700. And she thought this was all terrible liver issues and problems, and also myopathy she was worried about. It was just pure weightlifting. You can get enzymes in the thousands. If you do really, really big muscle-related things where your muscles ache after you do it, you can get very high elevations of AST and CK. Marathon runners are a typical example of transient elevation of AST.
Is this elevation, you think, related to ischemia in the marathon runner? Because we get ischemic bowel disease in a few patients who are runners.
Yes. And in fact, it can be related to muscle. It's felt that it's muscle injury and damage, and ischemia can be a component of it.
Good. We have a question again from Dr. Catherine Miller, who asks about the treatment of hepatitis B, which in the acute phase, at least in earlier times, was just supportive. We used to put patients to bed and hope they get better. Does that imply that acute hep B is self-limited, and when do we decide to treat acute hep B?
So we will often see people that present with acute hepatitis B, sexual transmission or blood-borne transmission. And in an adult, acute hep B in an immunocompetent adult is cleared in 95% of cases. So all we do is watch them. 1% of patients will develop fulminant liver failure. That's very bad. Those patients often will require intensive care and maybe even transplantation. But the majority of patients who are immunocompetent will clear. Patients that are immunocompromised, patients on chemotherapy, patients with HIV, they may develop chronic hepatitis B. But again, the key is during that acute phase, just like we used to do, follow them. Monitor the INR, the bilirubin, make sure that they don't run into problems with acute liver failure. If you're worried, refer them forward, and most people will resolve.
Yes.
We don't treat it.
Dr. Caterina Delcia asked about a patient with stage 4 CHF with dyslipidemia and elevated Lfts. Should we stop the statin?
No. No, you don't need to stop the statin. So if you have stage 4 CHF, what you have is another very common cause of chronically abnormal liver tests, which is congestion. So, congestive hepatopathy is very common, especially in older patients with ischemic cardiomyopathy. And here what happens is that there's a backwash into the liver, and the liver is congested. And typically what you see in congestion is you see moderately high ALT, AST, but you'll also often frequently see an elevated indirect bilirubin because the injury is all around the central veins. And these patients, what you need to do is diurese them. And if you can diurese them successfully, the liver function will improve. But again, if the person has ischemic cardiomyopathy, they're on a statin and they need that, I wouldn't stop it.
Do you ever decrease the statin dose? Dr. Catherine Miller says if the ALT is elevated, isolated elevation like greater than 400, can we decrease the dose or stop it? Or
I think if you have a person who has a normal liver blood test, you put them on a statin and you're doing your good monitoring every 3 months of their liver test, and you suddenly see a bump up to 400, that's an indication to stop the statin. Wait a bit, restart a different statin usually. Doesn't mean you can't try another statin. You can try another statin, but usually that we would stop at that. What I usually tell people is that a 3 to 5-fold increase over baseline is an indication when you're looking at a drug that there's significant injury. If, on the other hand, the bilirubin is ever elevated, or there's an elevation of the INR with any drug that you've started, immediately stop the drug. That is a serious liver injury when you see that.
Dr. Linda Hunt says, in young patients with abnormal LFTs, do you want to add a mono spot test?
Yes, but those patients should not have persistently abnormal ALTs, all right? So lots of viral infections, lots and lots of them, will cause transient elevations of ALT. Adenovirus will do it, mono will do it, CMV will do it, all these things can do it. And usually I would just totally ignore the liver test in those patients if they come in with features of mono and stuff. But yes, if you have a young patient and you've got an isolated elevated ALT and you think they might have mono, of course it's a reasonable test.
Finally, a brief question from Dr. Catherine Miller. Which statins do you recommend that would be less hepatotoxic than another one? Do you have a favorite one?
So I like pravastatin, and I'm only biased towards pravastatin because I did a clinical trial on pravastatin many years ago where we actually gave patients with Nash and hepatitis C pravastatin versus placebo and followed them and showed that there was no difference in liver function tests over time in pravastatin versus placebo. That was in the annals. And so I've always said, well, I have information on pravastatin, so I've always used that in my liver patients. But actually, to be honest with you, I think the use of any statin that you like is okay with me.
Good. Thanks for a great talk. I'd like to thank Shire, Viropharma Incorporated, UCB Incorporated, and Ferring Pharmaceuticals for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits. My name is Dr. Tom Lamont. Thanks very much for joining us today.